All right, so thank y'all for sticking in there for the last session of the day. So we're going to be talking about cystic fibrosis. And a little bit about the agenda that we're going to discuss is reviewing what cystic fibrosis is, because I'm sure a lot of you in the room might not be familiar with that disease. Then we're going to talk about the correlation of mental health as it's related to body mass index. Liz will come in halfway and talk about the body-mind connection. Then we're going to be reviewing a study that was an international study done on CF called the TIDE study. And then we have CF Foundation guidelines for mental health that Liz will be going through. And then we'll end with our pathway that we actually use at Children's of Alabama. So we'll start off with the prevalence of cystic fibrosis. So there's over 30,000 people in the US that have CF. And then if you look at the world, there are 70,000 people that have CF. It is mostly a disease in the Caucasian population, but it can be seen in all ethnicities. So with Caucasians, about 1 in every 2,500 births will have CF. And then it kind of goes down. 1 in every 4,000 to 10,000 Hispanics will have CF. 1 in 15,000 newborns that are African Americans will have cystic fibrosis. And we still see, I know at Children's, we take care of everyone in the state. Pretty much we're the only accredited center in Alabama. We do have some patients from Mississippi, I would say a few in Georgia, Tennessee, and Florida. But we find, I would say, average about 8 to 10 new diagnoses every year, but there's about 1,000 new cases in the US every year. And it's great that we have newborn screening in every state, so we're actually diagnosing these babies at birth. So, and the statistic was there were 75% of new cases are diagnosed by age 2. When I started working in CF, it was very relevant or prevalent to see patients, later in life that were really coming in because they had failure to thrive. And now we're actually diagnosing them earlier, so they're able to start on enzymes and start on vitamins. So we're not as much seeing that failure to thrive term that we used to see. So when we look at genetics with CF, to have CF, you have to have a mom and dad that are both carriers. So if looking at the picture at the top, you have the mom and dad, they're both carriers. So what is your percentage of having a child with cystic fibrosis? So it's an autosomal recessive disorder. So that means with each pregnancy, you have a 1 in 4 chance of having a child with CF, a 1 in 4 chance of not having a child with CF, and then a 50% chance of that child being a carrier. And one thing that as time goes on, there are over 1,800 mutations for cystic fibrosis. And we'll talk a little bit more about what that means. But it's important to know what is your gene mutation if you have this disease. So in people with CF, they have a gene that makes a protein that doesn't work well. So that's like the main problem with CF, that there's this protein that doesn't work well, which means there's sodium and chloride that cannot kind of go in and out of the cell. And this causes real thick, sticky mucus. So there is mucus that is real sticky in their lungs, it can be in their sinuses, and then also they have this very salty sweat. When they sweat, salty skin. So it used to be a long, long time ago, before they even knew what CF was, if you had a child and they tasted salty when you kissed them, they used to call that the kiss of death. So that's what they called. If your child tastes salty, that's the kiss of death. But now we know it as cystic fibrosis. So with this CFTR, which is your CF Transmembrane Conductance regulator, this protein defect, again, is what causes CF. So research has been done trying to figure out how we can treat specific mutations. So we have 1,800 mutations. So here we are, we have scientists working on how we can treat, again, certain mutations. Does anyone know when the CFTR protein was discovered? Any takers? Y'all probably weren't born still. It was 1989, so about 30 years ago. And that is really when I started working in CF. So it was like the hype. You know, we have discovered what protein, what's causing CF. So again, our researchers are working on these drugs, and now the FDA has actually approved some of these medications that is targeting certain mutations. So, and I've listed the drugs that started in 2012. So really, it's only been a couple years that there's actually been medications that CF patients can take that is making their protein work the way it should. So the first drug, it was called Kalydeco, that came out in 2012. So it was all the hype. Oh great, we've got this new medication. But it was only for a very rare mutation, which was only 4% of the total population. So you think of 4% of the whole population of CF, that's not that much. But those that did have that gene were all excited, they're gaining weight, their pulmonary function tests were like improving, they were just having all these great benefits. So of course the scientists are going to go back and try to find more different drugs to help some of the other mutations. So our Combi came out in 2015, and that was for another group of CF patients with a different mutation. And it didn't have, I don't know, I would say as great of benefits as the Kalydeco did. Then Symdeko came out a few years later, and this was a medication for the majority of our CF patients that have something called it's a delta F508, so that's the most common gene mutation. So the majority of those patients, and you had to be at least 12. So with drugs, you know, you usually start off 18 and older, and then once you kind of see that they're doing well, then they'll go from 12 and up, and then it goes 6 and up. It's just kind of a slow, I guess, process. But one of the biggest medications, the one from 2019, Trikafta, came out, and we have seen wonderful, wonderful things, and it's just so rewarding going to clinic. Some of our patients have only been on this medicine for 2 months, and like they've gained all this weight, and their functions are wonderful, and I just can't wait to see what's going to happen farther down the road. So that's just a little bit about the protein that doesn't work well, but we're seeing good results with these new drugs. So the modulator doses, the picture on the bottom on the left is little packages of the granules. So just think if you have a baby, you know, they're not going to be able to swallow a pill, so they would take these granules, and you have to take it with a fat-containing food, and that's literally written on the drug insert, so we have to educate families to make sure they know what a fat-containing food is. And then the cost is $300,000 a year. That's no big deal, right? But luckily, insurance has not had any problem, even Medicaid is paying for this medication, because these medications can add actually decades of life for these patients. So the lifespan now is around the early 40s, but we're saying that it can add decades to that. So we're talking they're going to have families, you know, going to college, and anyway, it's just a great thing. So then, as of 2020, 90% of all CF patients are eligible for one of these medications. So our group just got back from a CF meeting, and it's always a big hoopla when, you know, it's like, okay, now we have reached 90%. Everybody gets all excited. But anyway, this is good news. So again, we've talked about a little bit what CF is, but when you look at CF, it involves many organs in the body. It's not just the lungs. So if you start with the top of the head, the sinuses, so we have patients that'll come in, say they can't breathe, they can't smell, therefore they don't want to eat food, they just have all this pressure. Well, it's mucus buildup. in their sinuses. It's very common for our patients to have to go in for multiple sinus surgeries because they have this buildup of mucus or nasal polyps in their nose. And then with the lungs, you have, again, this thick, sticky mucus that is building up around their airways. And then germs are being trapped in the lungs. And then what does that cause? Bacterial infections, inflammation. And that's probably the biggest reason when our patients need to come into the hospital, because they have these bacterial infections. So skin, again, we've talked about the salty sweat. The liver, their biliary ducts are going to be blocked. Pancreas, their pancreatic ducts are blocked. Again, this is from mucus. And then the intestines, what do y'all know about CF? They cannot fully absorb nutrients when they eat. So those digestive enzymes are not able to actually work. So that's when our patients have to start taking pancreatic enzymes before they eat. And with all that, this is a main cause of malnutrition and poor growth, is because of the intestines not working properly. They can't get those enzymes, and even though we're prescribing them enzymes, they're still going to have some malabsorption. So if you were the dietitian working in CF clinic, what are some of your roles? Well, for the most part, our patients are going to be on a high-calorie, high-protein diet and unsweetened beverages. And the unsweetened beverages is because we are trying to prevent our patients from developing CF-related diabetes, which we'll talk a little bit later. So another reason why did these patients need to be on a high-calorie, high-protein diet? They might be working harder to breathe is one reason, and just these chronic infections. And then the next is pancreatic enzyme replacement therapy. So if you have cystic fibrosis, pretty early on in life, we'll do a fecal elastase to see if you are pancreatic sufficient or pancreatic insufficient. So 88% of CF patients are pancreatic insufficient, meaning they have to take pancreatic enzymes. And this is a great picture on the lower right corner that just shows what the enzymes look like. So let's say this is Curion 3000, Zimpep 3000. So these little beads, this is what some of our babies, like we're talking 2 and 3 months old, would have to take these with every single feeding. If you're breastfeeding, you've got to take one of these pills before every time you breastfeed. So you think about being a mom, that's not going to be that easy, but we educate the families to use applesauce, use a spoon, and it's not like you just do it once and you get it. It's definitely something that takes a while. But all these numbers by the enzymes tells you how much lipase is in each capsule. And really, I would say this is like for the babies, and it kind of goes up. So most of the older young adults that I see are on these bigger ones up here. And again, they'll take those before they eat their meals and their snacks. So vitamins, our CF population also needs to take a daily multivitamin, and this is going to be in a water miscible form, so it's easier to absorb. And what type of vitamins do they need? A, D, E, and K. And that's what the vitamins are called, ADEX. So it's your fat-soluble vitamins. And then as far as exercise, probably when I started working with CF, it was kind of not, I don't even know what you would say, but not many people exercise because they thought, oh, I'm going to die when I'm 20 years old. It just wasn't a thing. But we highly encourage any kind of activity. I would say a lot of our patients are very active. They're cheerleaders, they're football players. We have a lot of runners, but we want to encourage strong bones, which is of course great, but it helps with cough production. So you think about it, if you're a runner and it's going to make you want to cough, which is good because we want to get the junk out of their lungs. I mean, that's the big thing. We want them to not suppress their cough. We want them to cough up all that junk. And then another good thing is if we're trying to get a female, say that needs to gain weight, just encouraging like muscular strength, talking about exercise instead of, oh, we want you to gain, 5 pounds, to meet your BMI goal. They might be like, but my friends don't weigh that. They want to look like their peers. So just encouraging muscular strength sometimes is a good thing. So to estimate calories in this population, you want to use their actual body weight. And then we use the DRI for their age, and then just using an energy factor of 1.2 to 2.0. This is a calculation that people from, I would say, all over the U.S. that are at an accredited CF site use. So this is from the CF Foundation. Protein needs are going to be DRI times 1.5 to 2.0. And you kind of have to use your, I guess, common sense, but if you have an older adult that maybe has more severe lung disease, they're on oxygen, they're going to need more of that 2.0, because I know that's like, a huge range. Where did I just go to? Sorry. But this right here, like that 2.0 is more for you're extremely active. You've got severe lung disease. But if you have someone that maybe their BMI is at the 85th percentile, maybe they don't need as many calories. So that's just like a good range to go by. And then also, as we all know, that sometimes you can't meet your calorie and protein needs by diet alone. A lot of our folks, they just might not be hungry. So it's very common for them to be on oral supplements or appetite stimulants. And based on the CF Foundation from 2017, and this is in the US, that there's over 45% of the CF population taking oral supplements. That's a lot. I mean, that's about half of the population. And then as far as appetite stimulants, that's something that we would use if the patients are telling us, I don't have a good appetite. We're not going to put someone on it just because they don't weigh that much. It's going to be more on them telling us they do not have an appetite. And it's very common for our families to have to maybe cycle on and off the appetite stimulants, because if you just stay on them like forever and ever, your body just gets used to them and they don't work. So families might be on 2 months and then they're off a month. So you just have to make sure that you're kind of watching the patient and their weight gain. So if you have someone that's done the oral supplements, they're getting tired of them, they've been on the appetite stimulants, not working, and you're noticing either their weight or their BMI starting to fall off their growth curve, that's when enteral feedings might need to take place. And about 11% of the CF population has some kind of form of a feeding tube. But for the most part, G-tubes, gastrostomies is what we consider. And we want these patients to have a normal life. We want them to eat if they can eat. And we would normally just use like a drip feed at night. So maybe an 8-hour tube feeding. We try to provide them close to 50% of their calories at night, so then they can eat the remaining 50% during the day. I feel like most of our patients, if they have a drip at night, they usually do not want to eat first thing in the morning, so then you're looking at them only eating 2 meals a day. I work in transition clinic, which is kids ages 16 to 21, and the children that I see that have G-tubes, they're ready for them to come out. Just to be honest, we have not had that great of success. If they're younger, you catch it early. It's, I don't know if I would say a better buy-in, but once you reach those teenage years, they want it out. And I just feel like in the last year, we've had at least 3 guys that have been around 16, 17, and they just yank it out. If you're not going to take it out, I'm pulling it out. And they just pulled it out. So there you go. Even though it might be our advice to, let's see what you can do without using the G-tube, and it's just like, no, I'm over it. And it's more just self-confidence. I want to be able to, wear something tight-fitting, and I don't want, my button to show through, but you have to, work with your families. So the next thing is nutrition resources and referrals. I know a lot of y'all probably have already gone to WIC, might be familiar with WIC. So If you're under 5, that's a resource that we would use if they're on Medicaid to get their supplements. But what do you do when they're over 5? Does anyone know? So this is a good question. So first of all, if they do have Medicaid, which a lot of our, I'm trying to think, probably 65% of the population that comes to Children's is on Medicaid. We would see if they're on supplements and it's like greater than 50% of their calorie needs, Medicaid will actually cover it. So it's got to be like 3 or 4 cans a day for them to be able to cover it. Okay, so what if you get denied, which you do get denied if it's, not meeting their needs. We have, I don't know if there's anyone here from Children's Rehab Services, but it's a great organization that we have here in Alabama that acts as an assistance program. So they actually will pay for our families' visits to the hospital. They will cover their vitamins because that's something the insurance companies a lot of times do not support. And they will pay for supplements. So we are very fortunate in our clinic to have multiple resources. And then one last resource is, depending on what enzyme you take, a lot of our drug companies have programs that, just say you're on Creon, you can get a case of a particular formula, or you can get a particular protein bar. And what I do with my patients, because you think about it, you're going to get burnt out if you're drinking the same supplement every single day, and we're telling you to drink 3 or 4 a day. So they might drink supplements for a month, they might do the high calorie protein bars the next month, then they can go back to the supplements. So it's more of, they can pick and choose what they want, and that's shipped straight to their house. So anyway, that's just some good information. You need to know what resources are out there when you're seeing families. I know it's a little bit more tricky when you get to the adult population, but since I work in peds, I just know what works for our population. So what other complications go along with CF? So it's not just CF, and it's close to 85% of patients with this disease will have one other comorbidity. The most common one that I wanted to discuss is called CF-related diabetes, and it is seen in about 25% of our adolescent age. It's most prevalent around the age of 18. So I do work with a fair amount of our young teenagers that have CF-related diabetes. So when you're diagnosing this, it's not just by looking at a hemoglobin A1C. You have to have an oral glucose tolerance test, and this is something that CF Foundation has guidelines, and if you're an accredited CF center, which we are, we start at age 10. So we're having families come in, the child has to fast, you get a fasting blood sugar, and then we get one at 2 hours post. So it's just 2 sticks. And our kids don't like that. Who wants to come in and drink this nasty glucola? And some of our kids throw up, and it's not easy, but we're asking our families to do this every year. And it's more to screen for that CF-related diabetes. So if they do get the diagnosis, they're started on insulin. That's the only treatment. You can't use any kind of metformin or any other oral agents. It has to be insulin. So I could talk for a long time about CF-related diabetes, but we will not do that. But the next complication I want to discuss is anxiety and depression. So why would a CF patient be anxious or depressed? Well, it could be because they have a chronic disease. I mean, that's just, I would say, on the normal side. But with anxiety and depression, they might be put on medications. So it might be my job to just kind of, when I'm looking at their medicines, I'm not just looking at enzymes, I'm not just looking at vitamins, but I need to look also what type of antidepressant they're on, because there's some that can interfere with their appetite. So that's where Liz comes in, and she's going to dive in a little bit deeper into the mental health and CF.
So Valerie mentioned a little while ago the body-mind connection to health. And we absolutely see this bidirectional relationship between mental health and physical health. And so things like, you mentioned inflammation. Inflammation can actually, in the body, can cause depressive symptoms. Vice versa, depressive symptoms can also cause inflammation in the body, and that happens a good bit with our patients with this lung disease. And so some of the things that we see if somebody is having difficulty with depression, anxiety, or any other mental health concern, those are the reason we're talking about those is those are the most prominent that we see with this population. Clinic attendance, exacerbations, lung function may fluctuate, BMI may fluctuate, and then just quality of life. And so we're always trying to treat both and make sure that we're not missing something. Adherence is really difficult for our kids because we ask them to do so much. Airway clearance, multiple times a day. They're taking sometimes 20-something pills in addition to enzymes. With all of that, sometimes things just go out the window. And so what we have found is seasonal effects in terms of adherence. So like weekdays, if they're at school, they have a routine. They're going to be more likely to be adherent with their medications versus weekends. And then, during, school versus holidays or summer months, we found that children have more depressive symptoms with lower rates of adherence to airway clearance. And then children of parents with depressive symptoms were less likely to be adherent to taking enzymes, and that could be because their parent is really struggling as well, because we see this not only in the patients, but in the caregivers. So we're always working with our families to develop a daily routine and keep that going and see how we can partner with them so that when they are going home from clinic, that they have something that's manageable, and that we're not shaming them for not doing everything perfectly, because it's really, it's a very high standard of care. This is challenging for most anybody, and if they say it's not, I don't know how they're doing it. They're like super people. So I'm not sure if what y'all have talked about earlier today, but this is just, I like this definition of depression. A medical illness, so it is considered a medical illness that negatively affects the way you feel, think, and act. And so it's not just being sad or having the blues, but this would be something that goes on for a long time, weeks, months, maybe years, if not treated. And so sometimes people that have this on an ongoing basis can start to feel hopeless and lose interest in things that they normally would enjoy. And anxiety is normal. Like, I'm feeling a little anxiety standing in front of all of y'all right now. Like, that's normal, that we're all going to experience that at some point in time. But the difference is when somebody has a disorder that does not go away, it gets worse, and it prevents them from participating in everyday activities. And there's also anxiety centered on medical procedures that's specific to patients with chronic illness and CF. So back in 2014, the CF Foundation that Valerie mentioned, which gives us all of our guidelines, did a study called the TIDE study. And it was an international study, real big, 6,000 individuals with CF and 4,000 parents or caregivers were interviewed. And what they found was that patients with CF are 2 to 3 times more likely to have depression or anxiety than somebody in the general population. And that's a very significant amount. They also found that adolescents are 2 times more likely to be elevated on anxiety and depression if the parent is elevated. And so they were like, okay, we did this huge study, lasted, they started, I think maybe in actually 2013 or before that, but they got the results in 2014. So in 2015, they created CF mental health guidelines. And so just like we were talking about before, with the oral glucose tolerance test, this became a standard of care. This is something that is expected that we are going to address annually. And so what they said is, we want you to screen all patients ages 12 and above at least once a year for anxiety and depression. And then we want you to screen caregivers of patients 0 to 17 annually, but and you notice is the wording is a little different, offer it, because we can't, and we do not force children. If somebody was like, I'm not doing that, we'll talk about it. We're not gonna like, you have to fill this out, but it's specifically parents. Like if they're averse to it, we're just like, that's okay. We just wanna make sure that we're offering that to them to give them that information about what's going on with them. So then they also said, your center needs to have a stepped process for what you're gonna do if somebody does screen that they are experiencing anxiety and depression. And that could include, therapy, medication, psychoeducation, or any combination of those things. So they told us that the best ones to use for this, they looked at there's so many different assessments that you could use to look at anxiety and depression, but the CF Foundation really wanted us to use the PHQ-9 for depression and GAD-7 for anxiety. Multiple reasons. They're free. You can just go on the internet and find them. You can download them, use them quickly. They're brief, I think 9 and 7 questions, 9 for PHQ-9, 7 for GAD-7. There you go, 9 and 7. Reliable and valid. So we know that we're getting good information. These are not meant to diagnose anyone. These are looking at severity of symptoms, but it gives us cutoff scores for how severe somebody's experiencing symptoms. So 5, 10, 15. Couldn't be simpler. Somebody scores 5, between 5 and 10 or 5 and 9, mild. Between 10 and 14, moderate. Between 15 and up, severe. And so it just helps us very quickly to get information. We don't have to go back and take 3 days to score something. It's right there. We just go over it. It's also available in all major languages. So this can be, because this was an international study, this can be, a guideline that is international. The CF Foundation, I think, mainly addresses North America, but it can be used in other centers around the world. So I know you really can't read this, and that's okay, because I'm just going to tell you what it says. So the PHQ-9 is on the left, GAD-7 on the right. And so what it's asking the person that's completing this to do is to think back over the last couple weeks and to think about these lists of symptoms that are right here. And so the first one says little interest or pleasure in doing things. And so then they can decide, did they experience that symptom not at all, several days, more than half the days, or nearly every day? And then so they'll circle that, and that's how we score it. And so feeling down, depressed, or hopeless, trouble falling asleep or staying asleep. There is a question right here, thoughts that you would be better off dead or hurting yourself in some way, that we'll talk about how we handle that if somebody expresses suicidal ideation. And then the same thing for the GAD-7 with anxiety, just more about worrying, trouble relaxing, being restless. Pretty much everyone on answers number 6, something is never 0, becoming easily annoyed or irritable. Specifically adolescents, I'm like, if they score a 3, I'm like, it's fine. That's totally normal. All adolescents are irritated. But it's just the combination. When you're looking at any one of those symptoms in and of themselves, we're not gonna go, ooh, you're depressed because you're having trouble sleeping. But if you're having trouble sleeping, you're not enjoying life, you have all these other things going on, then we're gonna take a closer look. I've kind of gone through the cutoff scores for these, and let's see what this, you can kind of see this one. Can y'all see? Can you read the words? So, so when we do this, we had to come up, with a clinical pathway, or what are we gonna do? And so this is our algorithm, our nice little chart, that now is just part of what we do in clinic, or if I see people in my office. So if somebody scores 0 to 4, or even 1 to 4, we're just gonna rescreen the next year. We're not concerned about it. That's not even mild. We're not concerned about it. Unless they were to come in at the next clinic visit and self-report some other things are going on, then we would rescreen them. We're not gonna just ignore them and be like, oh, you're not due until next year. We're not gonna address that. But then if somebody scores between 5 and 9, we're gonna provide that psychoeducation about anxiety and depression, what that is, what that can look like in daily life. And then bring them at the next clinic visit. And they come 4 times a year, so every 3 months. So we would rescreen them the next time to see if that's increased, decreased. And at that point, if it has increased to moderate, severe, or moderate or severe, we would kind of go into all of these over here are similar. Oh, nope. All of those are similar. So we would provide a clinical assessment and then refer to a mental health specialist, which would be me. I'm the counselor that works with this population at the hospital. And if for some reason they don't want to see me, that's totally cool. I can refer them to somebody in their local community. We do offer e-counseling, so that is a barrier, and we'll talk about how well that went over when we offer that. But just we try to make them have access to resources so that it's not just like, I'm so sorry you're depressed, good luck with that, so we have something for them in that moment. And then we would also consider adding an SSRI, depending on if it's in the severe range, we're most likely going to be looking at, not me, because I can't prescribe, but talking to their primary pulmonologist about, this is how they scored, and I'll talk to the family if they're open to taking medication. A lot of families are, and a lot of families are not, and that's totally cool. It's just been found that the most effective treatment is coupling counseling with that medication if you're in that severe range. It's going to help you to be able to implement the skills you're learning in counseling much faster than if you have that medication support, than if you're just like, I'm really going to try to calm down by just doing my deep breathing or whatever it is that they're doing. And so then over here, this is about suicidal ideation. And so if somebody answered that question, number 9, and said, I've been thinking about that more than half the days in the last few weeks, we're going to talk about that. So we're not immediately like jumping up, ringing bells, or like running to the ED or anything like that. We're going to talk about it. Because a lot of times the question is worded, would it be better off if you're not here? And people do experience very commonly, adults, children, a lot of people that I see experience some sort of, I kind of just wish I could like go into a hole and not come out for a while, or, and not have to deal with anything. And so sometimes that is how they're answering that question. And so if that's the case, we are going to encourage them to get into counseling, and then we will follow up with them within 72 hours. If somebody says, on the other end of the spectrum, I have a plan, I know how I'm going to harm myself, I have intent, we're going to be walking them to the emergency room. And so that's kind of our mental health pathway for what we do with these screenings. So we started at our center in May of 2015, and we just had to pick a population because we knew we couldn't implement all of the guidelines just at once, and because it was myself and 2 social workers that were going to be responsible for getting these screenings done. And so we started with ages 14 to 21. And then in 2016, the CF Foundation gave grant money to add a mental health coordinator to help make sure that this stuff is getting done, because they were like, this is a lot. And so I was also working with another population in the hospital, but I was asked to be the mental health coordinator, so I let that go and took up this responsibility. It's more like data management, who needs to be screened, who needs to be rescreened, are we following up on things, that kind of stuff. And then we got really excited, and we went to the hospital, and we were like whoever tells you what you can and cannot do at the hospital. And we're like, we really think it would reduce barriers if we could do e-counseling, like telehealth. Can we do that? So we were one of the first departments. Like, I got this app that's HIPAA compliant and a little, camera on my computer, and we were ready to go. And people did not want to do it. We were so disappointed. I had submitted all this stuff to do a study because we were going to see what an impact it made on, reducing these barriers. People did not want to do it. And so we were like, okay, that's good information, but dang. So I think that what we took from that was, maybe it's not transportation that's the issue. Maybe it's not funds. Maybe it's not that I live in Mobile and I'm coming up here for clinic and I could only see you 4 times a year. Maybe it's that I have so much on my plate, I do not want one more thing. And so one more visit, and so I think that that's something that we took away going, okay, so how do we meet the needs of people, if they are not willing to participate in e-counseling, if they live far away or whatever, and I think just would be the same as somebody that if all of our CF patients lived locally. Some people are just not going to want to participate in counseling, and that's okay. But we still have plenty of people that do want to meet in person. They just didn't really jump at the chance to do the online thing. So in summer 2017, we expanded to meet the full guidelines of 12 and older. And then in January, we started with the caregivers, just because that had been the last piece that we were just trying to figure out, how are we going to do that? And so I just said, I'm gonna do it. And so I've figured it out how to knock it out quarterly to make sure everybody gets screened. And so I'm going to clinic multiple days a week to screen every caregiver of patients 0 to 17. And it's been good so far. I've had a few people that say, no, I don't want to do that, or I already see somebody for counseling and I fill this out every time I go, and so I'm not filling it out for you. And some people that said, I really am struggling and I'd like to follow up with you. So, I think just in the month and a half that we've been doing it, it's been helpful. So we're going to end with a case study. And we were trying to think of somebody that would be interesting. So we chose some siblings that 19-year-old female, 15-year-old male. Their background, socioeconomic status is middle class. Parents are well educated. History of family dysfunction and specific mental health concerns around mom. I first met the 19-year-old in 2016 when she circled 3 nearly every day of the week for the suicidal ideation question. And her physician at the time said she did not want to talk to her. She said she was not actively suicidal, and so it wasn't something where they were moving towards the emergency room, but they were like, something's going on. She really needs to be in counseling. And so the physician worked with them, and it almost got to the point where he was going to make a report to DHR because he was so concerned about the mental health of this child, because the family would not follow up with services. And they don't live locally. They live about an hour and a half, hour and 45 minutes away. So ended up they came a few times intermittently. They didn't follow up a ton, but I would see them a lot in clinic. But when they did come, the 19-year-old was telling me she had been in counseling before. A lot of things centered around mom, and mom, I think, has some significant mental health stuff going on. Very controlling, verbally, bordering on verbal abuse towards dad and the children in the home. And when she had talked to this other counselor locally, the counselor had encouraged her mom to come in and they have family counseling. Well, mom sabotaged it and then wouldn't let her go back. And so this 19-year-old at the time, it was 4 years ago, so 15, she's pretty there's nothing that's going to change. And if you try to bring my mom in and make this better, it's not. And that's what's making me depressed, and that's what's making me anxious. And we're going to look at her nutrition status and how these things correlate in just a second. Also of note, they have private insurance, and they do receive support from children's rehab services that we talked about that can help them with clinic visits and things and supplements. So the 15-year-old I've also seen intermittently for counseling, and they are people that, how I just said, if you score 5 and above, we're going to rescreen you. They're screened. I kind of had to, I want to be adherent to the guidelines, but we have screening them because he started coming every 2 months because he was sick, and I felt like he was just filling out something, it wasn't purposeful at that point anymore. But they have to be rescreened pretty much every time. Other diagnoses for him, he has atypical mycobacterial infection, advanced liver disease, and chronic sinusitis. He also has had migraines that have come up in the last year where it was making him not be able to see. And dad, when I spoke with him on the phone, acknowledged, I really think this is related to mental health, but they still have not gotten him in locally to see a counselor, will not go there. He is on buspirone, which is primarily addresses anxiety. The 19-year-old, she has asthma, atypical mycobacterial infection, chronic sinusitis, and osteopenia. So you can see under mental health, these are the averages of their scores over the last year, because I had screened them, well, like I said, a lot, so I didn't want to put every single one up there. So he averages about 15 in the severe range for depression, He has been on different medications to address both depression and anxiety, and he never really reports change, like anything helping to make it better. And then he's about 11 on anxiety, which I think is interesting that he's on a medicine just for anxiety, but he's higher on the depressive scale. But, and then our sweet female her average is 18 on depression. She's now in college, but just kind of still living at home with parents. She was really hoping to go to school a little bit away, and it didn't happen because she grew. That when Valerie was talking about the bacteria in the lungs, how the mucus, germs get stuck in there and then it grows bacteria, she got a really bad one. And she was having to get very intense treatment for that. And so then mom just used that as you can't go away to college because we got to address this. So it was really bad timing. But, and her GAD-7 is about 12, and her suicidal ideation is about 2. And every time we have a conversation, she doesn't ever have a plan. She doesn't ever have intent, anything like that. She says it's more existential. So that's her word that she uses, like, what's the point? She just doesn't really enjoy. So I'm going to let Val talk about some of their nutrition stuff.
So the 15-year-old, both of them are pancreatic insufficient, so meaning they do have to take enzymes. We usually we calculate it based on their weight in kilograms. And both of them are at the max for enzymes, meaning there's kind of like a safe zone for how many you can take, because you don't want to sit there and take 10 pills before every single meal. But based on their weight, they're kind of like at the max amount of capsules. So just to give you they still have a lot of malabsorptive symptoms. He actually drinks 4 Boost Plus a day, which I think it equals around 50% of his needs for the day. And sister does not like the milk-based beverages. We've tried so many things, and finally she settled on drinking Boost Breeze. And she will drink 2 of those a day. She definitely will say she does not have an appetite, so she is on cyproheptadine, which she takes that daily. So, and neither one of them have a G-tube. So this is our 15-year-old male, and I kind of want to show you. So this red curve down here, and this is what we get on all of our patients, and we're able to show the families this at every visit. So this red line is the BMI, the blue line is weight, and then the green is the height. So this was like the last time I saw him. Weight was great, height great, he's definitely tall. And his BMI is at the 47th percentile. So our goal was around 50th to 85th. So I would say he looks, pretty good, even though to me, he still looks tall and lean. And he's a big swimmer. That's one good thing, and I would say that's great for his lungs, but he goes to a place where he swims at least 3 days a week. Okay, for our female, her weight is at, so sorry. Okay, so this little red line, again, just shows like her BMI. So if you look at hers compared to the brothers, it's definitely has been low. And one thing, like around this time, is when she got this atypical bacteria, which she was put on chronic antibiotics, where sometimes it could be up to 4 antibiotics a day, IV, and that alone causes nausea, diarrhea, a whole lot of things. So that could be one reason why she had this big drop right here. And this is just a cute little picture of our team. So we were, this is an annual meeting that we have with the CF conference, and this was in Nashville, and this was probably just part of our team, but we're very involved in research, QI projects. It's just kind of a thing, part of our team. It's just like we're always doing more. We don't just see patients, we're always trying to improve things. So anyway, most of us were either presenting or doing posters at this conference.
And some of the slides that I presented were prepared by some members of the CF Mental Health Advisory Committee, so I just wanted to give them credit for that. I think that's it. Do y'all have
so now,
questions?
Does anyone have any questions? Questions or concerns? Yes?
So along with like mucus.
Uh-huh.
And have y'all looked at like any different levels of serotonin and how that could possibly be affecting?
Levels of serotonin. So Harriet, she asked if we had looked at levels of serotonin. She's not listening to me. Regarding that, I personally do not know the answer to that. Yeah, I would have to ask one of our pulmonologists that question or Google that. You have?
Well, when I was in my CF rotation.
Okay.
But we still.
Okay. You must have worked with Juliana?
Yes.
Yep. Okay. She's all about QI. Yes.
You might have had this in the slide, maybe I missed it, but what percentage would you say of CF patients like have anxiety and depression?
How many have anxiety and depression?
Well, symptoms are diagnosed.
Probably like symptoms.
I mean, I would say maybe about 30%.
Is that just of our population or?
Yes,
or-
of people that we are screening, it's been about 30%.
Okay, so just locally. Yep. Yes.
So when you were talking about the medication doses, like towards the beginning, you said that they had to take it with like a fat-containing food. Is
Yes.
there, like, a specific amount of fat that they have to have?
That is another good question. Anybody wants to do some research on? No, there is not a specific amount. And the drug company that has come up with those 4 different modulators, it's all the same company, and on every insert it just says take with a fat containing food. And one of my trainees, interns from last week, had developed a nice handout that, shows what fats, what would be a good source for them to take with their medication, because they're supposed to take it 12 hours apart. And it's kind of comical what some of our patients do eat. It's like, oh, I have 2 Reese's cups and a glass of milk. I mean, that's like their breakfast in the morning. But no, there is not an exact amount, and that's something that, as a whole, the CF Foundation is trying to, I guess, someone do some kind of research, but we don't know exactly. But we just say, like avocado or a glass of milk. So it's not like a substantial amount of food. Any other questions? Yep.
Do you have patients who are really obese or overweight?
Yes.
How do you manage their?
Yes. Great question, because that is an interest of mine. So the question was, do we have obese CF patients? So with the introduction of these modulators, we are seeing obesity and overweight patients. So with these medications, we're seeing all these great things. Some of our patients have been able to come off enzymes because they have been gaining so much weight that we slowly kind of titrate them down, and they don't have to take enzymes. I just, this morning before I came here, had a phone call from a mom, 18-year-old son with CF. He was on Kalydeco. So when it came out, it was 2012. And he had gained so much weight. I mean, he was at the point of, he was definitely overweight, that we weaned him off his enzymes, and he did fine. So he has not been on enzymes since around 2013. Well, he just came off Kalydeco. He's been off for maybe 3 or 4 weeks because he's about to start the new medication, Trikafta. Well, he's having symptoms. He's having loose stools. He's having bloating. So he's definitely having malabsorption, which he has not had since 2013. So he's about to start this new medicine, but we did have to just restart his enzymes. But back to the obesity, we're going to have to start rethinking. It's not like a one-size-fits-all, everyone's on a high-calorie, high-protein diet, but there are a fair amount of our patients that are just on a healthy diet. Eat your fruits, eat your veggies, do my plate. But that's definitely coming down the pike, that more and more people are seeing obesity. And I want to say the last time I looked, if I can remember, it was around 7% of our population, just at children's, with CF that had obesity. So it's there. Yes.
We're talking about a 19-year-old. What age do you all have to stop seeing?
21. Yeah, on your 21st birthday, they go to the adult center at UAB.
So I've read or seen in different articles and journals that CF patients can have lots of pulmonary exacerbations with big life changes like going to college and things like
Mm-hmm.
that. So are there resources like at Children's or UAB for patients that are making those sort of like big transitions that might affect their CF?
So are you saying if you're sick and you have to come into the hospital and you're in school, or?
Yeah, or like, I don't know, when I was at UAB and
Uh-huh.
then just like in the pulmonary unit, when I was talking to some of the nurses, they said that some of the physicians that they work with aren't, I guess, supportive of some of their kids going to college because they neglect their CF sometimes.
No, we're all about,
That does happen.
Like living-
We're all supportive of them going
Yes.
to college, but that does happen just
Okay.
because as we were talking about, like the routine, they have to develop a new routine. And what does that look like? Now I don't have mom or dad to remind me of things. And so in that transition clinic, we have been working with them since age of 16 so that they are the ones that are answering questions. They come back by themselves for part of the visit so they know their meds, they know what's expected, and we try to encourage more ownership of their daily care by the patient at home so that when they go, they already know how to do it, but they are still going to have to develop that new routine. And so sometimes it does. It's like, oh, well, I've been at class and I've gone out to fun parties and I've got all these things and I haven't been doing my airway clearance, and different things. So it's definitely an adjustment, but I think that
but you want to encourage a normal
Yes,
life.
right.
You want to encourage, you want to exercise, you want to go to school. But we do have a lot of, I would say 19, 20-year-old, for some reason, males that love to play video games, and that's their goal, is just to play video games all night. It's like, no, you are functioning, you can go to college. But, so anyway, we strongly encourage to continue to live a normal life. No questions, Harriet?
Well, I am interested for your clients that have to be on any kind of a medication for depression, for example, what are you using?
it's different. I think our different physicians have ones that they like. And so there's typically going to be an SSRI, so Lexapro, Zoloft, are kind of some of the first go-tos. Most of our physicians are comfortable starting a medication, some kind of antidepressant or anti-anxiety, but if there have to be changes, they will refer to a psychiatrist. So they just say, if this works, that's great, but beyond that, I really think if you're having more needs, and they're not going to get into changing things around a whole lot.
Okay, thanks. All right, thank y'all.